Working, there we go. Why? Sorry, I'm having some, I've pinned, there we go. Sorry, Judy, I pinned you by accident. So welcome everybody to this evening's Over the Bloody Moon Masterclass. We had a lot of interest around intimate health. We often don't think enough about it. It's a really important topic. And as we're going to learn, there are some kind of common experiences as we transition through menopause and beyond. And there are things that we can do to manage those symptoms and prevent them. So really delighted today to welcome Dr. Sharma. We have partnered together on quite a few masterclasses over the past few years. Dr. Angela Sharma forms the other half of dynamic duo at Spiced Pear Health, which is a menopause clinic specifically as well, with an expertise in intimate health. Dr. Sharma is and has been running her own NHS menopause clinic for many years before menopause was sort of hip, and is a real advocate in the space. And she also, as I said, is co-founder of Spiced Pear Health. So we'll be sharing details in the newsletter about that. As well as a GP, she is also a European clinical sexologist, so very well qualified to talk on the topic today. We do understand that it's a sensitive subject. We are recording it, and there are we had a good response, and there will be people. Sorry, I just see there's people in the waiting room. There will be people watching on catch up as well. So, but if you do have any questions and they're sensitive, then feel free to just pop them in chat and DM me. So let's get going. We're going to have a bit of a fireside chat. There will be opportunities as well at the end to ask some specific questions to Dr. Sharma. But, you know, there's a lot going on in terms of hormones for women's bodies. We often think about kind of like the psychological aspects and things like hot flushes, but it can sort of impact people in other ways in terms of intimate health. So it'd be great to hear a little bit from your sort of patients, like what are the most common experiences that you come across, and just talk a little bit about those.
Sure. Thanks, Leslie. And it's really nice to be here to be able to talk about this subject. I think the first thing to say is how difficult it is as a subject to raise with your health professionals. And I think if you look at the studies, they've shown that only 25% of women actually ask about this symptom or ask for help about this symptom or get help for it. And 70% of doctors know about this symptom, but 70% don't ask about it. So that's the scale of the problem, basically. It's something that all women will go through at some stage in various degrees of severity, but it will impact all of us at some stage going through menopause. But it's such a difficult topic to raise and difficult topic to talk to your doctors about. So what I would say the first thing is if you're suffering from any of these symptoms that I'm going to mention in a few minutes, then make sure that you raise it with your doctor and don't just sit on it and don't suffer silently, because there's all these treatments and things that we can give to help. So the main things that I hear are, and it's because of the lack of estrogen, the reduced blood flow down to that area, reduced sensitivity. You get vaginal dryness, you can get itching as well. Not only inside the vagina, but also in the vulval tissue. The whole area can become quite dry and irritating. Women can get bladder becoming a little bit weaker, so you start noticing that you're going to the toilet a bit more frequently, or waking up in the night to go to the toilet, or maybe you're leaking urine a little bit. And also this is where prolapses happen. And so you get loosening of the sphincter around the bladder. So that's what causes the leaking. And also you get recurrent urine infections. So some women might just present with recurrent urine infections around this time. Some women might present with pain. Some women might present with prolapses, which is just a loosening of the pelvic floor. It feels like a heaviness inside the vagina. It's quite a few different symptoms. And then someone might say low libido and all of that as well. and then you have to kind of unpick it all and work out, well, what is it? What does someone mean by low libido? Because actually they might mean just pain during intercourse, or they might mean just the dryness, or problems with the urine leaking and things like that. So there's quite a few symptoms. And then one of the other ones that pops up quite commonly around this time is something called vaginismus. So when a lady's had a lot of pain during penetration, then sometimes, well, not sometimes, the body will remember that. And so the next time you go into that same situation, you just tense up. And so the muscles tense up. And so it becomes even harder to have penetration, and that causes more pain. So you're setting yourself up in this vicious cycle, which then obviously impacts intimacy and relationships, and just filters down into the whole relationship with your partner as well.
And of course, for some
Quite a lot of
people,
symptoms, yeah.
yeah, and for some people, if we can just ask everyone to pop themselves on mute, if that's okay. For some people, there may also be trauma, associated with sex, and with menopause, some of kind of like our past issues can kind of catch up with us as well. So
I think, this is an absolute time where you're kind of reassessing everything. I think, psychologically, physically, emotionally, lots of things are changing, and so you naturally want to question what's happening to you, and then thoughts from before or previous trauma. This is where it kind of erupts. And if you've had sexual trauma and you've got vaginal dryness or pain, then that can trigger that as well. So it's a very sensitive topic. It's very hard to raise with a doctor, or for a doctor to ask you about. So it's something that we have to tread very carefully when we're asking people, but it's something that I would always want to ask, especially if someone had low libido. I would want to delve really deeply, unpick some of the layers, like why is this happening? And that would be one of my questions. I think, everyone's different. So, you can't assume that everyone's got trauma. So you have to ask. It's a sensitive way of asking about it.
Definitely. So let's talk about what doctors call vulvovaginal atrophy.
Yeah.
Which is, as you said, kind of itchy, sore, dryness, etc. So let's talk about kind of like the do's and the don'ts around sort of supporting that.
Yeah. I think the main thing to remember or to understand is that the tissue has become drier, and it's really delicate as well. So you've got to be really careful what you're putting on that area. And I think a lot of women will want to keep that area clean, and maybe want to clean inside. So one of the first things I would say is absolutely don't insert anything inside, don't clean inside. The body's got its own way of cleaning, and it keeps the pH low, keeps the bad bacteria low. But obviously with vaginal estrogen dropping, the pH starts to rise, and this is when you get more bad bacteria, but they're on the outside, so not generally so much on the inside. So I would just avoid anything also that's fragranced or perfumed, or anything with any harsh chemicals. What I generally ask my patients to do to take care of that tissue is to use things that are for eczema or dry skin conditions. So using things like Oilatum, it comes as a shower gel, or E45 wash. It's really moisturizing, and you can also use things like Cetraban or Epiderm to moisturize the tissue, or if you want to go something very natural, you can use coconut oil, but all external and nothing internal. So that's the main thing. It's just, and when you're coming out of the shower, not to really vigorously rub that area, just gently pat and keep dry it gently. Just really take care of that tissue. I mean, it's the same as also, take care of your face. It's the same as taking care of the tissue down there. It needs kind of daily looking after, daily moisturizing, daily washing as well, but not overwashing as well.
And one of the things we might not think about, but it's like if we're standing in a shower and we're washing our hair, the kind of the chemical
the products,
shampoo may also
absolutely,
be an irritant. So kind of leaning over, and anyway, we should be using more gentle products for our hair.
I think hair shampoos, if you look at the list of ingredients, got huge amounts of chemicals and things inside them. So if inadvertently anything gets on there, then just give it a good clean, or wash down. So make sure there's nothing that lingers down there as well.
And what about topical estrogen? Can you tell us a little bit about that and how that's helpful?
my first go-to if someone has some of these symptoms would be to go for something that doesn't have just washing the area nicely with E45 or Latem, using emollients like Epiderm or Cetraban or coconut oil on the outside. If you're still having dryness or irritation or pain, then the next thing that I would go to is two things. One, if you are having sex, always make sure you use a lubricant. And there's lots of different lubricants out there, and then some of those can irritate as well. So I would, the one I recommend to all my patients is generally the Yes brand.
Mm-hmm.
And I don't have any affiliation with that company. It's just time and time the feedback that I keep getting back from patients that it feels comfortable and it's very much like your natural lubrication with very little chemicals inside it. So that's just to use during sex. If you in between, if you're still having dryness, then I would use a vaginal moisturizer first. And
Mm-hmm.
again, the Yes do a vaginal moisturizer. And what that does, it's the same as moisturizing your face. So
Mm-hmm.
it's moisturizing the tissue internally. And what you do is you do it a couple of times a week because it lasts for a couple of days and it brings moisture to that tissue, keeps the tissue smooth and stops that dryness and irritation. Obviously, it's not going to be like vaginal estrogen and make the tissue go back to how it was, but it just helps with dryness if that's your main symptom. If you continue to have symptoms and you've done all of those things, then the next thing I would think about is vaginal estrogens. And there's lots of different versions of vaginal estrogen. So the difficulty is when you go to your GP, and I'm guilty of this myself, when you are familiar with a certain product, you only kind of recommend your patients one type. But actually, it's good to know about all the different versions because if one type doesn't suit you, then you can try something else. So it can come in the form of a pessary, which you just insert yourself, or a little tablet that comes with an applicator, one that's throwaway, one that's reusable as well, form of a gel, and also a cream. And sometimes I mix the cream and one of the other vaginal estrogens together, especially if you've got external symptoms as well. And then there's also the ring, which is a bit like a plastic shower ring that's quite bendy, and it sits inside the vagina around the cervix and it just releases estrogen continuously. So there's lots of different versions, and there's no right or wrong. And I think what I tend to do is I tend to tell my patients about all of them and say, well, which one suits you and which one
Mm-hmm.
it's like the sound of, because I want my patient to make sure that they use it regularly, and I don't want people to just start using it and think, oh, I don't like this, and then not use it.
Mm-hmm.
So if you're finding something doesn't work, then go back to your GP and ask for a different kind of product. But the impact that that small amount of estrogen can have is huge, in that pelvic, bladder, vulvovaginal tissue. And it can have a huge impact and help the tissues go back to how it was. And so the key is really starting it as soon as you have symptoms rather than waiting till later, because then it takes a lot longer and sometimes you can't reverse some of the changes as well. So I always like to get my patients on it as soon as possible. As soon as they have any symptoms, let's just start it straight
Mm-hmm.
away. Usually you start them like a daily basis for about 2 to 3 weeks, depending on which product. And then once you've got that estrogen in that area, then you reduce it down to once or twice a week. Sometimes
Mm-hmm.
some people need a little bit more, sometimes some people need a little bit less, but that just maintains the tissue.
And
And
it's
if you
different to systemic HRT.
Yeah, it's very different to systemic because it just works locally in that area and
Mhm.
very little is absorbed into your system. So it's not really an alternative for systemic HRT, but it's just a really good one to add on to
Mhm.
systemic HRT, especially if you continue to have symptoms, even on
And
systemic HRT.
exactly. And some people that are not on systemic HRT for various different reasons,
They can still have
they
it as
can
well.
still,
Yeah.
yeah,
So
exactly.
there are patients obviously of cancer and estrogen sensitive cancers. And
Hmm.
there's a statement by the British Society of Sexual Medicine on vaginal estrogens. They've looked at all the data. And for those women who are on tamoxifen, then they're saying that it's safe to take vaginal estrogens. Obviously, if you're on aromatase inhibitors, then the data is not so solid, but there are alternatives that you could try or ask your oncologist to switch
Hmm.
you over to tamoxifen. But I think this is something that needs a discussion with your oncologist, and every
Yeah.
woman should be taken individually about their risks and understand. But generally, if you're on tamoxifen, it's safe. And all these women are missing out because nobody's talking to them about it. Nobody's
Hmm.
saying to them, you can have this, and they're just suffering silently. So yeah,
Yeah.
if you are if you are, then please download that statement and take it to your oncologist and
And
use
the
that
other,
as a discussion basis. Yeah.
yeah, and the other group where sort of this is particularly important is for those people experiencing premature or early menopause, because then, of course, you've got a
Absolutely.
longer term impact.
Yeah. So those women will experience menopause symptoms for a lot longer. You know, normally we think about vaginal dryness happening post-menopausally or in someone who's not taking HRT. But if you're on the, you know, if your menopause starts much earlier, it's going to happen much earlier as well.
Mhm.
And for these women, they might still be, you know, obviously very sexually active, and it can have a huge impact in their relationships as well.
Yeah. So thank you so much in terms of covering sort of that area fantastically. I want to move on to urinary tract infections, UTIs, because this is something we hear a lot
Yeah.
about. And for
Yeah.
some people, it really can impair their daily life. They feel that they're kind of on a continual sort of cycle of antibiotics.
Oh, yeah.
What can be done? Is there any, and
Yeah.
also kind of lifestyle as well? What are kind of your
Yeah.
tips?
I think your infections recurrent at that time. You have to think about what's the main thing that's going on. And the main thing that's going on is that low estrogen, which then, uh, because the lining inside the vagina and the bladder becomes thinner, and less, the muscles in the tissue become weaker. So
Mhm.
also the vaginal tissue, the food for the good bacteria goes down, which is this lining in the cells. And so you get this more bad bacteria in that area. And so this is what you get the recurrent infections together with that weak bladder. So my first instinct in a woman going through perimenopause or menopause, postmenopausally, who's got recurrent urine infections, I would want to give them some vaginal estrogen just to
Mhm.
sort that side of things out first. If someone continues to have um, infections, obviously you don't want to keep giving antibiotics. So one of the things that I would do is I would want my that lady, if she's not, if you keep doing urine tests and they keep coming back, you know, negative, and someone's still having all of these symptoms, I would want them to be investigated a little bit further, because what you don't want to miss is something called chronic inflammation in the bladder, which presents as recurrent urine infections that just don't get better. You have the antibiotics for a few days, you feel better, and then as soon as you finish them, they come back again. And what the urogynecologists do is they do different things. So they'll have a look inside, they'll take a biopsy of the bladder lining. They might give you 6-week rotating antibiotics if they find that there's bacteria
Mhm.
inside there. Some use bladder installations. So you go in and have an infusion of a liquid inside the bladder that calms things down. Others use antihistamines because sometimes it's the histamine that's overdoing it that's causing the inflammation in the bladder. So there's lots of different treatments for that.
Mhm.
But one of the things, if it is recurrent urine infection and the vaginal estrogens are working, then sometimes if it's linked to sex or having sex, then what I do is sometimes give a tablet, an antibiotic tablet that you can take just after sex, just to break that cycle as well.
Mhm.
Also just thinking about how much fluids you're drinking, you know, just reducing your fluids in the evening so you're not going to the toilet at night while waking up. I think you can take cranberry extract and things like that over the counter if you're finding that difficult. And just really thinking about alcohol intake, just reducing all of that. Thinking about what you're doing in terms of pelvic floor as well. So to tighten all those sphincters up, making sure you're doing some pelvic floor exercises. I think it's not just urine infection and it's not just here's the antibiotics. I think sometimes that's a wrong treatment and you want to look a bit wider at all these other things. But
Mhm.
obviously everyone's going to be different. So, but generally I've kind of covered all the things that I would do, all the things that I would look at. Yeah.
Yeah, brilliant. And we have had sort of sessions before on pelvic health, but it seems important not to ignore it. So, what kind of pelvic dysfunctions might happen sort of in perimenopause and beyond?
So you have to think about what the pelvic floor does, and the pelvic floor is like a hammock, and it holds up your bladder, it holds up your uterus, and it holds up your bowels. And as it starts to loosen, then the sphincters in all of these areas can become a bit looser. So you might leak urine, you might notice a prolapse of the uterus, or sometimes people get a rectocele, which is they find it hard to open their bowels because their stools are getting stuck in that little pouch. You can, by examination, you can tell which one's which, and to the degree with which it's happening. But I think the other thing that the pelvic floor does, it's really important for your orgasm. So it contracts when you have an orgasm. So what women notice is weaker orgasms, or the orgasms aren't as strong as they were before perimenopause. So in terms of exercises for it, it's one of the first things is you've got to do those exercises properly. And I always like my patients to see a pelvic floor physio, because that way the physio is going to actually map, and they actually examine people internally. So don't be shocked if you go to the physio and they start examining you internally. So they're trained to do that, and they will find those areas where the muscle's a bit weaker, and there might be some areas where the muscle's a bit tighter, and they'll give you quite specific exercises to do. And some of the exercises are short tightening and then releasing, and some of them are longer tightening and releasing. And it's also, it's not just the tightening, it's the relaxing as well that's really, really important. So yeah, you can also download the Squeezy app, which is the NHS version, just to remind you to do them. I always ask my patients to do it while they're brushing their teeth, because you're going to do it twice a day, every day, and that way you're not going to forget. And you don't have to do a lot. You just have, if you could just do like, say, 5, in the morning, 5 in the evening, but if you're doing them every day, it's really going to help keep that pelvic floor tight. So it's not a lot of exercises that you have to do.
It's
It's
so
the regularity of it.
important, isn't it?
Yeah,
So,
and the only time we talk to women about it is during pregnancy, when actually it's something I always tell my patients, it's not something you just stop, once you've had your baby. It's something you've got to carry on doing.
yeah.
And
Well,
it can save you all of these problems later on. Yeah.
Yeah, in the pelvic floor Bible by Jane Simpson, she's
Oh yes,
been
yeah, I love that.
research, and she says 65% of women postmenopause will experience some kind of incontinence, and yet a simple squeeze a day.
Yeah.
A few squeezes a day will kind of really put that at bay. So I hope everyone is squeezing now. We've got the rest of the session to continue to squeeze. So we've kind of, is there anything else at all that what about I can never say it, lichen, it sounds like a Scottish, lichen sclerosis.
Oh, lichen sclerosis. Yes, yeah.
Thank you.
So yeah, so around perimenopause, there are some skin conditions that sometimes seem to appear, or they're still not sure what causes it. May be related to estrogen, or estrogen, or may not be. But lichen sclerosis are like white patches around the vulval tissue, and they can be incredibly intensely itchy. And so if you have any hardening skin, or white patches, or intense itch that's not settling, and you've tried your Canesten or your thrush treatment and it's not getting better, then I think that always needs examining. The problem is there's a very low percentage, I think it's less than 1%, can turn into a cancerous version of it. So it always needs examining, and it needs monitoring as well. So what I usually do when I see ladies and I've examined them and I can see that, then I send them to the vulval clinic, and they usually get put on some high dose steroids just to calm it down. And obviously all the stuff that we were talking about before, just using E45 or Latem, using a Epiderm for moisturizing, and then the strong steroid cream just to calm that itching down. You can't stay on it long term, because obviously that's going to thin the skin. So you just use it for 2 weeks at a time till it calms down, and then have a break off it, and then use it again if needed. But it's something that needs monitoring. So these women need to be kept an eye on, and if something changes with that tissue, then that needs a biopsy, and will need investigating.
So again, don't kind of delay. And this is a bit unfair because it's not a question that was written down, but in terms of gynecological cancers, we unfortunately hear so many people not going to the doctor, or it's hard to kind of detect. But what are the common symptoms associated with biggies?
I think you have to think about what are the common. So it's cervical, it's ovarian, it's uterine. And so you want to make sure that you are not missing any of these. So keeping up with smear tests for cervical, you know, it's over the age of 50, it's every 5 years. So just make sure you go and don't miss that. If you're having vaginal dryness or pain and you're worried about being examined, then just use some vaginal estrogen. You can ask the nurse to give you some for 2 weeks, 2 or 3 weeks before you go for the test. That should really help the tissue. Sometimes you might not have any symptoms for that, and it's only when picked up on examination, but they will check for HPV, which is the virus. If you have high risk, then they will just monitor you more closely. Sometimes if you get any bleeding or spotting in between your periods or after sex, those are the things that really make me nervous or worried. I always want to investigate that. I want to really find out, where's this bleeding coming from? Is it coming from the cervix? It's coming from higher up. If you, for ovarian cancer, usually people get bloating, they get lower pelvic pain, sometimes pain in the back, sometimes pain going down the front of the thigh is another symptom as well, which could also be ovarian cyst, but also ovarian symptoms. And there's a blood test you can do for that to check CA125. You can ask your GP to do that. Uterine cancer, again, it's bleeding and spotting. So these are the women who maybe don't take their progesterone in the right dose, or on HRT and are bleeding outside of the normal pattern, or are on no bleed HRT and suddenly start bleeding. So I would always want to investigate those as well. But just basically in that area down below, if something's different, something's changed, you know, it just doesn't feel right. And as women, I know my patients, I know they know when something's not right with them, and they will come and tell me like something's changed, something's different. That always makes me, you know, a bit more worried about my patients. Like, okay, I need to investigate this because something's changed for them. And obviously any excessive heavy bleeding or pelvic pain that doesn't go away, should just go and go to the doctor and get it all checked out. And if you're worried, just start with the nurse. She'll do the examination, she'll do the checks, and you know, a bit more accessible maybe sometimes the nurses.
So another area that gets a lot of topic and interest is around libido, and we often actually think about kind of low libido, but one can also get surges as well. Someone actually has sent a note to say, I'm postmenopausal, I'm on Everol for 75 and Eutogestrone. For most part, all my symptoms are well managed, but without my cycle, I don't have monthly ups and downs anymore, and that includes sort of libido, feeling more or less interested. I miss that element. Are there any suggested tweaks? I know you can't give individual advice, but I mean, what is going on? Why might people feel kind of horny on some days and not at all on others? And
yeah, I think if you look at a normal natural cycle, what you get is that rise in estrogen mid-cycle. And with that, you get a slightly rise in testosterone. And then once you've ovulated, then the levels drop down again. And that's the time when most women will feel like a couple of days before ovulation will, but that's natural, isn't it? Because that's what you want your body to do, is to have sex so that you get some sperm in there and get the eggs to be ovulated. So that's the normal cycle. But what we're doing with HRT is we're giving you that nice steady level. We're not trying to mimic a normal cycle anymore, because it's the fluctuations that give the symptoms. So this is where for those women who are sensitive to that, because not every woman is, but there's some women that are sensitive to that up and down of the estrogen, testosterone, then they're the women that might feel that lack of rise and feel like they don't get that mid-cycle surge of sexual activity that they want, or the libido that they want, which is a bit difficult because it's counteractive and counterproductive to what we're trying to do with the HRT. So for someone like that, I might consider testosterone, just maybe upping your level slightly and getting it steady so that you've got that all the way through.
So with testosterone, how do you sort of assess whether that might be a reason why someone, you know, would benefit?
Yeah, so the advice is that you shouldn't really start anyone on testosterone until their estrogen's normalized. By that, I mean, if you're on HRT, then you want to get your levels somewhere between 200 to 600. And if a lady's got their estrogen between 200 to 600 and they are still having low libido, that's when I would add in testosterone. The reason why you don't add in testosterone before that is because in a female body, it gets converted back to estrogen. So you're actually taking it and it's pointless. It's not doing anything. So this is what I see is a lot of women who have been started on it at the same time as they started HRT, and they're saying, well, it's not really doing anything. But also, like, it's really interesting because when you look at the data, the women with low testosterone don't always correlate with low libido. And women with high testosterone don't always correlate with high libido. So there's some discrepancy there about level of testosterone as well. And what I see in clinical practice is, yeah, there will be some women who I'll give testosterone to, and it's absolutely what they need, and that's what they needed for their libido. And then there'll be another group of women who you give testosterone to and it doesn't work at all. And it's because this is what I think anyway, is that's not really what was the cause of the low libido. And when I look at low libido, I'm not just thinking about, as a sexologist, I'm going to do a bit of a wider search. It's not just about your hormones, or what's going on in your body. It's also maybe what's going on in your mind, the things that you're thinking, anxiety, stress, all of these sexual scripts, the things that we've picked up along the way in terms of previous relationships, cultural, religious, what we expect to happen. And, all of these things are going on in our head, but also what's going on in your relationship. And I find sometimes for those women that testosterone doesn't work in, it's because we haven't addressed those areas. And it might be marital conflict. It might be that they've just fallen out of love with a partner, or there really has been some trauma in the past that hasn't been dealt with, or they're under so much pressure or stress with work, that having sex is the last thing that they want. So that's the cause of their low libido or the relationship problems, not really low testosterone. So if someone is coming to me, I'm not going to just ask you, here's your testosterone, off you go. I'm going to be looking at all of these areas with you. And you can do that yourself. You can ask your question to yourself. You don't have to go to a sexologist, but you could just say to yourself, well, what is it that's stopping me from having sex? And you think about it as brakes and accelerators. I really like that analogy of sex, of, what's making you want to have sex and what's stopping you. And if it's not really looking at the things that to make you want to have sex, it's looking more at the brakes, because once you take your foot off the brake, then everything's going to go anyway. So look at in your relationship, look at in your mind, what are you thinking? Is because to have sex is a very mindful exercise. You have to be in your body, you have to feel the sensations, the touch, you have to be focusing on your senses. But if you're up here in your head and you're worrying about what to make for dinner, I've got this big meeting tomorrow, or I'm going to have pain, I'm worried that, I've put on weight, I don't look so good. If you've got all of these things going on in your head, then you're not going to be in your body. So it won't be an enjoyable experience anymore. So,
and the other thing I remember from one of our conversations is that oh my God, I've got complete brain fog.
that's okay.
I was gonna, I mean, I remember talking as well about, for example, if someone's got urge incontinence or
Yes.
incontinence, the kind of the fear,
Oh, that's a
am I going to
huge one.
leak,
Can you
if I
imagine?
orgasm?
Yeah.
Oh, that's what I was going to say, is also like arousal
Yeah.
post sort of, the menopausal transition. Suddenly we might not sort of get that urge or that feeling anymore. And yet, so kind of how do you overcome those kind of issues?
Yeah, I think the testosterone and estrogens obviously needed to prime your brain to think about sex, to want to have sex, and then it sends messages down to your nerves, blood vessels, and and that then triggers arousal, which then hopefully triggers orgasm. But if you've got reduced blood flow, you haven't even got the thoughts first of all, then you've got reduced blood flow and then reduced sensitivity, and then someone's touching you and it doesn't feel the same as it did before. And so it might take a lot longer to get aroused, or you might not get aroused at all. And so this is what then the whole experience becomes really unpleasurable for women. And so this is why you start avoiding sex and just, I just don't really want to go there. I don't want to feel that pain. I don't want to, it's not really doing anything for me anymore. And I don't even feel like it. So how do we get women back on, out of that? Obviously, the way I look at it is the biopsychosocial. So what's going on in the body? Let's think about things there. Let's think about what's going on in the mind. Let's think about what's going on in the relationship. So for the body stuff, I would think about testosterone. As long as the estrogen's normal, I would think about recommending vaginal estrogen, vaginal lubrication, and making sure you're using all of those things. Just to take away the pain, because that's one of the things you definitely don't want to have. And then thinking about, I recommend a clitoral stimulator to my patients, actually, because what that does, that's an external, so nothing internal. It just is a vibration applied to the clitoris, and it increases the blood flow, increases sensitivity. I think women have to remap their bodies. They have to work out, how they like to be touched again, because it's different now. So you do have to send people off and work out, some of the exercises to do, to work out that. And then in terms of the mind, if you've got body image issues, if you've got stress, if you've got anxiety, then we've got to deal with all of those things. And I think if it's sexual trauma, then you might need some therapy for that area. And then relationship wise, there's all the stuff with the relationships that comes up. And then so some people might need couples counseling. Some people just need to talk to their partners. And I think that's such a difficult thing. Again, you can talk to your partner about everything else, but sexual problems can be really, really like a brick wall, finding it really hard to find the right words as well. So sometimes a psychosexual therapist could help you with that area as well, and help you communicate better with your partner.
And of
But
course,
it's not just one solution.
yeah.
There's so many different things, and there's all these psychosexual therapy exercises and things that you can do. Sensate focus is one of those things where you go back to not having penetrative sex. It goes back to touch and touching in non-sexual areas and sexual areas, and just taking sex off the table and just getting back with your partner and getting that intimacy back. Even just hugging and kissing and holding hands and just doing those things first. But it's not a quick fix, but there's lots of things that can be done. And I think it depends how you want to handle it. Like if it's something that's important to you, important to your relationship, then definitely go out there and seek help, because there's lots of people that can help you, and don't give up. So I think that's the problem. There's a real myth that sex finishes after menopause. I keep hearing that time and time again, and it doesn't have to be like that at all.
Yeah. And there'll be plenty of people not in a relationship.
Yes, yeah,
and the importance as
or
well
who
of
don't want to have sex as well.
Yeah,
That's fine
so
as
the
well.
importance of self-pleasure as well is
absolutely.
something that kind of we don't talk a lot about, but is actually really important for intimate health, because as you say, it stimulates kind of the blood flow.
Blood flow, keeps your sensitivity. Yeah.
So there is kind of I've heard the phrase, use it or lose it, and that the aging process around the skin tissue can accelerate if it's ignored.
You have to be a bit careful about lose it in if there's pain involved. So not to force through or grit through pain. You can say no and stop and go and get something and sort that side out first. Before you start doing things like that. Yeah.
Great. Okay. So I think we've kind of covered a lot. I think is there anything else before we sort of open up to people to kind of share questions? And you can also, if you haven't already, DM me with any sort of personal questions to share. But is there anything else, Dr. Sharma, that we haven't covered in terms of the do's and the don'ts and who to see?
I think there's some really good books. So for women going through menopause, it's really important to learn about. When I learned about it, I was fascinated. It's such a fascinating topic. Just learning about yourself, learning about your body, what works, what doesn't work. And there's some really good books. So Mind the Gap by Dr. Karen Gurney is one that I recommend. And the other one is Better Sex Through Mindfulness. It's by Laurie Brotto. And then she's got some really good exercises in the workbook there to go through to really get you to focus on your senses and get out of your head and more inside your body. So yeah, I would recommend that.
I'm just putting those in the chat. So Mind the Gap is by who?
Dr. Karen Gurney.
Karen
Gurney. It's spelt Gurney. And the other one is the Better Sex Through Mindfulness workbook by Laurie Brotter.
Brilliant. Okay, fantastic. So that's in the chat. Thank you very much. Open floor. Does anyone sort of got any other questions that they want to ask, either for themselves or something that you've noticed that we haven't covered?
It's a tough one to ask about.
I have a question,
Yeah,
if it's all right.
of course.
So I was given, because I know you can't speak on a personal basis, but I was given the HRT gel, and then I found my dogs started licking my skin, which then it got to the dogs and excuse me, the dogs grew nipples and all sorts. It was very, very dangerous. So I got changed to the tablets, and they're working fine, and they're talking about the testosterone as well. But I was wondering, is there a certain level of HRT tablet you can take, or is there different types of tablets?
Yeah, I think that it's difficult because with the transdermal HRT going through the skin, you can actually check levels. But with the oral estrogen, you can't, because it's a slightly different type of estrogen. So you can't actually check levels. So I would actually use your symptoms as a guide. So if your symptoms are well controlled and you feel good on it, then that's when I would add in the testosterone. Most of the HRTs, 2 doses, I think, are 1 milligram or a 2 milligram. So
Yeah.
if you are having symptoms, then I would go up to a 2, but some of the HRT doesn't have 2 milligrams, so it depends which type you're on.
Right. I mean, I'm having a consultation with the GP this week about it, but I was just wondering what different options were available for that.
Yeah, and in terms of testosterone, I tend to prescribe the male version because we don't have a licensed female version here in the UK. There is one available privately called Androfen, but it's quite expensive, and it's the same ingredients as the male version. It's just in a pink packaging, so I tend not to prescribe that. So if you're going to your GP, there's 3 different versions that you can have. One is like a sachet, and one is like a tube, and the other one is a pump. There's just to be aware that the way you take it is different depending on which type of product you use. I found that the tube and the pump are really hard to get hold of sometimes, so I generally tend to prescribe the sachets. They're really readily available, and you would use 1/8 of a dose, so a pea-sized amount, making that 1 sachet last 8 days.
And where does that go on your body?
So you can apply it anywhere on your body, but if you keep applying it to the same place, you tend to get excess hair growth. So I ask my patients usually to apply it somewhere where we have very little hair follicles. So that could be inner wrists, collarbones, or behind the knee. Those are the 3 areas that I ask them to apply it.
Interesting.
Thank you.
Fantastic. Thank you so much. Thank you for asking that question. So we've had another one sent, which is with regards to vaginal atrophy. If
Yeah.
you've been diagnosed with it, is that then for life, or can it sort of with the treatments and suggestions?
So if you've been diagnosed with it, then it means that the tissue has got to that stage. The estrogen's low enough that it's got to that stage that you've got the dryness. So if you use the vaginal estrogen, your tissue will go back to being normal as long as you started it early enough. And then it will stay normal. But the minute you come off it or stop the HRT, the tissue will go back to being dry. So it's difficult. Like, yeah, it is lifelong, but it can be treated. And all it needs is just a little bit of maintenance treatment on a regular basis to stop the tissue going back to how it was. The reason why I like women to start using it early is just because if you leave it for a really, really long time and you don't get treatment, then the walls of the vagina tend to stick together, and all the labia start to disappear. So that can be really, really hard to reverse later on. So I mean, that just stops some women from having any sex because the tissue's stuck together. So I hate to see that in a woman, because that means that we left it so late. So I've seen that once, so it always shocks me.
Yes.
So always like my patients to start early the minute, and also I ask everybody about it. So what
Mhm.
I see is those women, they'll tell me about all of the other symptoms, hot flushes, mood changes, all of these, but they'll never mention vaginal dryness or low libido. So I'll wait till they tell me all the symptoms and then I'll ask them about those. But
Yeah.
just, you know, don't forget to tell your doctor about those symptoms.
So a couple of trends on TikTok and Instagram at the moment. Just interested to
Oh
hear
yeah,
your view
there's always
on
something.
collagen supplements and laser for kind of
Yeah.
intimate health. So what's
So
your
so just going to laser treatment vaginally. So there has been some quite good data to suggest that the laser treatment can reverse some of the changes. And I don't think it needs many treatments. I think it's just a couple, and then once a year a maintenance treatment. I think the problem is that there's no long-term safety data for this stuff. So the British Menopause Society at the moment is not recommending that we do that. But you know, if you're really desperate and you've tried everything and you've tried the estrogens and it's not working, you tried the different versions, they're not working. And I do know some women have gone off and had that done and it's really helped. So and unfortunately it's available privately only. So you'd have to find a clinic that would do it. And then collagen. You mean collagen generally for the whole body in menopause
yes?
or yeah.
Yes, I mean everywhere's like,
Yeah.
I've always
It's a
been quite
really interesting
skeptical
one.
about.
Yeah, but loads of my patients take collagen because I always want to know what supplements women have tried.
Yeah,
It's fascinating how people have tried all sorts of things before they get to me, you know, and looking for HRT. And I understand that. I get it because I'm the same, you know, I want to try something else, you know, before I had to go on HRT. I wanted to know what else I could do to help myself. So I totally understand, but a lot of this stuff doesn't have any evidence. And I know that whenever you look at the packets of collagen, they always say, oh, evidence suggests it works and everything. There's no long-term solid, you know, randomized control, double-blind trial saying that collagen works. However, anecdotally, like all of my patients swear by it.
Mm.
And they all say that they feel some difference or some improvement in their hair, skin, nails, joints. And that's really difficult then to say to someone, well, you know, stop it because, you know, there's no evidence for that. So what with all supplements, what I always ask my patients to do is try it for a month. If you notice an improvement or something that helps, then obviously carry on taking it. If it doesn't, then don't waste your money on it. But I think I know everyone's going to go away and try stuff. So but I always think about, okay, well, that's something you're going to start. You're going to feel good on it. It's going to help. How long are you going to stay on it?
Mm.
And what's going to happen when you stop? Like, will
Yeah,
everything go back to being how it was again? You know, so I think then you have to factor in the cost of these things and whether that's something that you want to stay on. But I know everybody wants to try it. Yeah.
yeah.
And there's lots of
So,
different versions, lots of different brands, you know, which one's right, which one isn't that. I don't know.
yeah,
Everybody seems to be on something different. So it's not something consistent that I hear from my
yeah.
patients.
But when it comes to sort of the vaginal vulvar tissue, we're talking about gentle moisturization, pH balance,
Yeah.
blood flow, sort of, yeah.
Yeah.
Okay.
Get your vaginal estrogen early if you've got symptoms.
Yeah,
Always talk about it to your GP. Don't forget to mention it. Yeah.
brilliant. Well, thank you so much. Is there any sort of last questions before we wrap up? No, if you want to as well, just pop for those that are live in the chat, sort of a key takeaway. That would be really helpful. But thank you so much again for joining our community. It's always such a pleasure.
Yeah. It's lovely to be back again.
Yeah, I always learn so much.
Yeah.
And I think sort of, the key takeout is we all know what doesn't feel right. So don't ignore it. Go and see a GP. And if you're lucky enough to have a GP like Dr. Sharma, then definitely get in touch. And also afterwards in the newsletter, I'll be sharing details of how to get in touch. But do you want to just kind of do a little signposting to your clinic and how to get in contact with you?
Yes, so we are an online menopause and sexology clinic. So we cover both of those areas. Everything's automated, so you just book via the website. There's myself and my business partner, also Dr. Angela Wright, and it's just the two of us. And you will get a consultation with one of us. and we're both trained in the same way. So she's also a sexologist as well, and GP.
Brilliant, fantastic. Well, thank you so much. Lovely to see some familiar faces, and welcome to some new people as well that joined, and have a lovely evening. So thank you very much.
Thank you.
Take
Bye.
care. Bye.